Thank you all, and welcome back. I'm noticing a lot of handshakes, a lot of hugs, a lot of I haven't seen you in a while. So there are a lot of folks in the room who know one another well, who are very familiar with this issue, and who may very well know the gentleman sharing the stage with me. So Dr. Brendan Carr is the Chief Executive Officer and the Kenneth L. Davis, MD, Distinguished Chair of Mount Sinai Health System, and is nationally recognized as a leader in academic medicine and health policy. Dr. Carr has practiced clinical emergency medicine for more than 20 years and is a renowned clinician and health policy researcher. He's focused on building regional systems of emergency care and has served in an advisory role to domestic and international organizations and is a member of the National Academy of Medicine. He previously served on the faculty at the Perelman School of Medicine at the University of Pennsylvania and as an associate dean of the Sidney Kimmel Medical College at Thomas Jefferson University in Philadelphia. In addition to his academic accomplishments, Dr. Carr is well-versed in being in the Hubert Humphrey Building, having served the Department of Health and Human Services in a variety of roles focused on improving trauma and emergency care delivery for the nation. I'm not quite sure how this conversation is going to go. We've known each other a while, and I expect I'll ask some questions, and you'll take things in the direction that you want to.
Get me to say the things the general counsel told me not to say.
Not at all.
I imagine.
It'll all be good. So, Brendan, one of the reasons we wanted you to join us here is you have a pretty unique perspective. I don't personally know anyone else who started their career in emergency medicine, moved in and is now into administration, is now the CEO of a hospital system, also still a practicing emergency department physician. So I'd love for you to cast your mind back a little bit. Back, you know, earlier this morning we were talking about the impact of boarding. Now we're going to talk a little bit more about a whole bunch of other variety of things. So back when you were an emergency department physician, and that was all you did, right? Research, all the other things you did, but that was your primary day job. How did you view the problem of boarding, and what did you think the causes were?
First, you know, this is a hard room to be in, and thanks for letting me be here. There's the expertise in this room about this issue is shocking, and it, you know, we all have just a little bit every once in a while of imposter syndrome. For me, talking about boarding and crowding in this room, I've got it. Even though, you know, I have some domain expertise here, this is an unbelievably rich room, and I think that our agenda and our priority today is less about educating the people sitting here and more about capturing for posterity sort of, you know, the narrative about this issue, really helping people to see the whole issue, because we know that this is being broadcast and being recorded so that we can educate people who have not been steeped in this. And so while it's true technically that I'm still a practicing emergency physician, the medical director who controls that is here, and I noticed that he's putting me in the more protected area of the emergency department, which anybody who's aging in emergency medicine knows when they start doing that to you, it feels a little bit funny. So the early days, right? When you get exposed to emergency medicine, you know, you're a medical student. You're trying to understand this practice all through residency and fellowship. At some point, you don't know when it is, but I became much more aware of the larger issues that were driving this agenda, some of which you're hearing people touch on and think about already today. But just thinking about those early years, it's crystal clear, you know, when you're a resident, what's happening. And what's happening is that we are intentionally marginalizing either these patients or this specialty. It's what it feels like, right? Because those are the patients in front of you, and you're watching them suffer and wait. And so, you know, I think the pure answer to your question, as a doc, I'm watching that, and I'm feeling like, you know, like it must be intentional. I don't know who to blame, so, you know, we blame the folks that are closest to it, which is to say hospital administration. And the other pieces, though, you know, is that it's really hard to not think about what it signals to you as a doctor, not just that my specialty is not important, my patient's not important, these patients aren't important, but then what it signals to the patient. And you heard some of that. And those, you know, thank you for being brave enough to share it. I've lost eyesight, or maybe Chastity left. But, you know, to hear the degree to which people are wounded by and feel marginalized by the fact that we're treating them in this way is meaningful. I just said to Robin, I texted my dad while I was sitting here, and I said, hey, I'm about to give a talk about crowded hospitals and, you know, all the problems, making sure that we can make supply and demand meet for the healthcare system. Do you mind if I out you and say that I was powerless to get you treated in a room last time you were in the ER, and that we sat in the hallway, you know, waiting for your workup to happen for a couple hours? And he said, yeah, but you're so numb to it that if you're going to tell the story, tell it right. It was 3 times. You didn't get me in a room any of those 3 times, and thanks for nothing. I don't know why I waited all this time for you to go to emergency doctor school. So you know, it is everywhere. It's super pervasive, and the targets are easy to identify. You know, where I think the conversation will go today will be about how we really open the aperture and start to understand that, and it's been appropriate the moment you let them speak. I don't know if they're going to, you know, come at me, but the moment you let them speak, they all said, come on, this issue is so much bigger. We're not having a conversation about the ED today. We're not having a conversation about crowding or boarding. There are specific definitions for those words. We have, you know, slurred them today. We've sort of muddied the waters a lot. What we have said is that we do not have a strategic approach to how we are planning for the acute care needs of the American public. Right? Like, we don't have a game plan. We don't understand what our capacity is. We don't understand where the hockey puck's going to be as we make more ambulatory things happen. We don't have any sort of air traffic control over it. So we'll get to these things, I'm sure. But you know, it is when you are in the moment, it is very easy to know that this person is being marginalized because of something about them, something about my specialty. I'll just say, sort of, my beginning zoom out was I did EM, and then I did trauma, surgical, critical care, and then I did delivery system and health policy research. And so my zoom out came when I started to do sort of real delivery system science, when I really started to understand the bigger pieces that were at play here. Some of that was the things you heard about. People that are boarded have worse clinical outcomes. Right, that's as true as true could be. It's terribly impactful on patients and the workforce. You know, these are things I started to see, but I also, and I know we'll get to it, started to see the financial drivers that were underlying that we have to be really clear about. We went through like 2 hours of talking about this issue without talking about incentives being misaligned and without talking about payers. The closest we got to it was, I have no role in private equity, Brendan. I don't know where you are. My namesake out there somewhere said, that's the closest we got to it, was talking about private equity. And, you know, but we have to talk about the misaligned incentives, and I know that we will.
Absolutely. And so the way I wanted to take the conversation next, you just set it up beautifully, is, so you started out thinking, you know, must be something about these patients or my specialty that is, you know, being put in this special category of getting less attention. Now that you're running a large hospital system with 8 emergency departments, how do you see the issue differently?
Well, I mean, you know, I'm never going to not see the visible in front of me. There's just more things visible to me, right? So it becomes about the Zoom. It becomes, I get the phone call once. The word escalated is a problem that you know, is now part of my life. I get the phone call about the transfer that we won't take in, who's going to, you know, have a horrendous outcome if they can't get the resources that we have. And so, you know, that very clearly means I'm the person deciding that person staying in the hallway if I take this person into the ICU bed, or that person I never want to work at that critical access hospital that was referred to earlier with 3 crashing ICU patients, you know, and the inability to transfer them out. But I can solve that problem for that ER doc. It just means that my ER docs are still staring at the boarders in our hallways that can't get upstairs. So, you know, that is, I still see it as from the doctor perspective. I still know what it means to greet every patient with an apology, right? Every patient you see, I'm sorry it's so crowded in here today. If you know, at least that's how I enter, trying to disarm a little bit and trying to de-escalate. And I also, you know, I just spend real time thinking about, you know, what they do when you get a new job, they put your title on your white coat, which means now if I'm going to wear that white coat to go see patients in the emergency department, someone is going to notice and think that I'm responsible for how crowded that place is. But I did, sort of go back there with a fleece on, and see patients, because we have to be reminded about how real it is. So I'm never going to lose the sort of that doctor perspective. But I get the complaints not just about what happens in the emergency department, but the escalations about how patients need to be transferred in, about the other services that are trying really hard to do their lens on what's good for the broader community. And I have to ask myself now, not am I going to prioritize the patient, but which patient are we going to prioritize? And then we are going to institutionalize that. But I wouldn't be an administrator if I didn't instantly talk about finances, right? Because, I know that, the afternoon we'll spend talking about solutions. Someone needs to say at the top of this program, and I'll be that guy, that we created these incentives that have gotten us to where we are, and we can uncreate them. It will be hard. There's not a silver bullet. I know we're talking about solutions later, but we have to be really thoughtful about how we line up the Swiss cheese and or implement the multiple different levers it's going to take to get us to a system that thinks and functions differently. We are an academic medical system, and it's very personal to me to be from not just an academic medical system, but an academic medical system that was built with a deeply ingrained service mission. I mean, the story of our health system is that it was built by resource Jews to take care of marginalized Jews as a hospital. The hospital then built a medical school then sort of built a health system that's got an enormous footprint across Manhattan and beyond. So it's sort of a non-starter for us to walk away from the service mission. That said, it turns out we have very smart financial people that say to me, but if you cross this line, you sink the ship. So, just make any decision you want. Do what's right for, the world out there. But just know that, you could very intentionally, if you just want to snap your fingers and make all the boarding go away by canceling a quarter of our elective surgeries, it would be very easy for you to sort of undermine the health system finances. I'm sitting here in front of a room full of folks that are faced every day with patients staring at them, scared, angry, and very clearly blaming the system. But that system has a face and a name, and it's the doctor and the nurse that are the ones that are not letting them have a bed upstairs in their experience. And it's hard to say, yes, but. That we have to think about, on balance, the whole of the system. But that's I think the story. This is a smart crew, right? That's the story we have to tell, which means we then have to broaden. We have to zoom out once again and say, who are the people that are driving those levers? I think they're right over there, right, on Capitol Hill. They're distributed around us. We didn't take a show of hands to say, who's from where in the federal government or in the private sector, right? We've not yet talked about the role of payers in this. We've not, and we'll get there, we've not talked about our big gamble on changing incentives for CMS to decrease the cost of health care, then necessarily translating into the private sector payers, where instead of decreasing the cost to the American public, it either decreased the cost to employers and, indirectly to us, or it maximizes profits, right? This is just how our system works. We have to say these things out loud without judgment. This is how the system works, and we have to be, I think, really clear-eyed about the fact that those are the forces at work. And I think that understanding and thinking about this narrative that we've gone down, that we can avoid, you heard them say it, and I'll hammer it because it was there, but to some folks it might not be clear. Avoiding low acuity emergency department visits doesn't fix this problem. It's not actually the problem that we worry about when we're all talking together. We can manage that. We're actually, someone said victim of our own success before. We're quite good at the churn. It has its own problems, right? Unless we can connect them to long-term care for some of these conditions, I think in safe spaces we would say we could do better. It'd be better if I started their blood pressure medicine because they didn't know they had the disease, and then I handed them off to somebody. But the low acuity stuff is not the thing. We don't like when you call patients inappropriate. right? We don't even like, sort of unnecessary. We could sort of understand avoidable, but we got to be clear what you're talking about when you say avoidable. Low acuity stuff where someone has another choice. Okay. Someone who's getting admitted, so getting back to the conference here, so my dad, technically, none of those 3 times was he admitted. He had 12, 18-hour workups. We would leave, and he'd say, I can't believe I was there 16 hours. And I said, I can't believe you got an MRI, a CAT scan, all those labs, and saw a subspecialist in 16 hours. That's astounding, Dad. Nowhere on earth does that happen. And he would say, I'm not speaking to you anymore. Please just drive me back to my home. So there's differential expectations, but we have to I'll take a pause here and say we just have to have the broader conversation of if we're muddying it here, and the central narrative is that there is a mismatch between supply and demand, and between patients' expectations, payer expectations, and provider expectations. Well, then let's carve out little pieces of this and take them on, because it's too big to boil the ocean all at once.
For sure, and we'll definitely take some time to do a little bit of a deeper dive together about payers and financial incentives. But before we do that, I'm curious, what is it that keeps the problem physically in the emergency department? What prevents it from becoming both actually a whole hospital problem where patients may be boarded elsewhere in the hospital, but also what prevents people in the hospital and in hospital administration from viewing it as a hospital-wide problem?
It's interesting. That's a hard question for me to answer because, I think I am hospital administration now, right? Something happened, and so the idea that it's not a hospital problem. It's not even a hospital problem, really, right? I mean, Aisha, what did you say up there? She said. Health system capacity, she had a thing. We're talking about the health system. That's what we're talking about. We're talking about the U.S. health system and the degree to which we do or don't have a game plan for when things go bump in the night. We have an okay game plan for when things go bump during the day. Okay. We don't have any game plan for when they go bump in the evening or in the overnight or on the weekend. And we have a lot of incentives that set it up so that we will not have a game plan for that. So what keeps it out of the line of sight of a non-emergency physician hospital administrator? I think that answer was different a decade ago. I think it was hospital boarding, in their eyes a decade ago. It is a much different thing now. And I think that, at least the people that I talk to know that it's about throughput. And then the question becomes, I just said throughput because there's a standing model, probably written by the people in this room, that there's inputs to the system, there's the ability to sort of create throughput, to optimize the space that does exist, and there's outputs. And you have to think in those 3 terms. That's 20 years old, that literature, and it still works. Is that, it's about sort of what can be diverted elsewhere, and that's less than we think, because people need the ED in the hospital for a lot of resources. Coordinating laboratory and expertise and imaging in the outpatient setting is really hard. And then, but so they need they need efficient throughput, and then they need output. And you heard people talk about this. You heard them talk about getting people to rehab, getting people to nursing homes. And you heard people talk a little bit about social determinants of health. We only believe in paying for those as part of value-based care, and I don't know why, right? We don't really believe that there's a fee-for-service world in which housing security, food security, and a little bit of support at home is something that a payer would pay for. We only believe in it if a health system takes the risk of generating value, and I don't know why that is, right? It feels like healthcare. And by the way, if you ask like regular people, the American public, I think they would tell you that they think that healthcare includes like a warm, safe place to sleep as they're getting better from their gallbladder surgery or their, sort of pneumonia. And that's not how we function. So I think that administrators have gotten there. I think that the modeling that has happened to sort of create this framework of, all right, there's preventable stuff and there's technology, and we're diverting and we're trying to be smart about it, and we're going to, 10 years ago, urgent care was not normal language that people used. maybe 15 or somewhere thereabouts. It exploded. It's everywhere. I think that the throughput piece, we've gotten really good at. It makes me sad when I hear about some of the stories from earlier about whether or not you're seen and urgently evaluated. You know, we generally get eyes on people very quickly to make sure that we can start their work up, or that, and this part stinks, that they, in doctor brain, are safe to wait. You know, that's sort of the, you know, you are triaging, you are prioritizing. So the throughput stuff we're getting better at, and the output stuff, you know, is held back by lots of payment and regulatory pieces. I think administrators are there. What they're not there is they can't see the future. They can't see the path forward because they're limited by the barriers that are in their way. So the topic, you know, the language has changed, the conversations have changed, or I changed the conversations by being in the room, which may also be true, right? I mean, is that people, you know, are more open to having a real conversation with it because they understand that it's near and dear to me.
Yeah, so I'd love to turn to the question of financial incentives, value-based care, payers. What is it that, obviously you mentioned very briefly earlier, you know, canceling elective surgeries is one way, of course, to clear the emergency department of borders, and that's not financially feasible for the hospital. What else is it about current payment policy and some of the payment models that we're experimenting with nationally that helps with boarding, that causes more challenges for boarding? I'd be curious on your perspective.
Yeah, well, so this one's, you know, this is a giant one. You know, it's interesting. When you asked how it impacted me, I'm glad to see one of our hospitalists, one of our head hospitalists here. But when you asked how it impacted me as a trainee or as a junior doc, what I didn't say is that it also separated us from our peers. Right? I mean, every emergency physician, in fact, every emergency physician and the one internist in the room, right? Think about how many conversations you've had about whether or not this person needs to be admitted, right? And what is the grounding conversation there? It's a rule book from a payer that says whether or not this person we will get reimbursed if they get admitted. That is our grounding framework that pits internist against emergency doctor and results in Brandon's slip up about you know, being assaulted by a doctor. You know, it creates authentic conflict to say they don't need to be admitted. They just have X, right? That could be treated at home. And then, right, say it with me if you're an emergency physician. They don't have a home. Right? Well, but they still don't meet inpatient criteria, right? So now that risk, all that cost is shifted to the hospital. So, you know, I mean, I think it's in addition to sort of marginalizing, you know, chewing away at the moral fabric of the docs, making patients feel less seen and less valued, and separating the specialty. Your question is, what are the payment drivers, right, that really are baked into the fabric of how healthcare works? Well, that was one, right? There are criteria around whether or not you can get paid based on severity of illness. There's not a counterfactual that says, if you have these 10 things that make your life stable and you're able to manage this at home, or if you feel comfortable and safe managing this by yourself at home, there is just a rule book that says these things are outpatient things and they can be managed there because we want to bend the cost curve. We want to spend less money on healthcare, and emergency departments and hospitals are cost centers. It just leaves out the patient's voice, you know, and so that's a piece of one. There are, you know, and I sort of don't know where to go with this because, yeah, right, I mean, every emergency physician, every departmental administrator, and every ED chair will tell you that this would just be better if we just had a 7-day work week for everybody like we have for emergency docs. We call that, you know, surgical smoothing. We'll just make them operate on Saturdays and Sundays. I guess if you own the entirety of the market and all of the doctors. I do not. It turns out there are other hospital systems in town that would happily grab them and tell them, you don't have to operate on Saturday, Sunday, or the evenings here, right? So, you know, that we have to, it's a lever that could be used, but it's a lever that has to be used thoughtfully. so I mean, I guess I would say that any of the financial levers, I mean, and obviously, well, let's just enumerate a couple more because they're going to be talked about this afternoon. Hard stops. You heard Eula talking about geriatric emergency departments, and and other countries, and have talked about a hard stop for how long you can stay post-admission in the emergency department before some penalty, non-payment or something else. There are consequences associated with that, right? I mean, those consequences are, one, to the financial bottom line of the hospital, right? And that would, from the ED perspective, that might feel just fine. As you zoom out, what does it really mean, right? Does it mean that I would stop allowing surgeries? Right, wearing the, administrator hat, would stop allowing surgeries for people that are high risk or people that are marginalized and more likely to bounce back into the emergency department, so that I won't have post-surgery, post-medical intervention of some sort, the risk that they're gonna bounce back and need to be admitted since I don't have capacity? Maybe, I mean, are there other unintendeds of that? Always. So, we want the magic bullet and the payment levers. I don't think and I didn't say, and I'll say it again, and why don't we pay for things that are not healthcare, right? Why don't we pay for things that are the underlying drivers of healthcare if it's going to decrease the overall spend?
Yeah, I'm mindful of the fact that 50, 60 years ago, Jack Geiger was writing prescriptions for food to be paid for by Medicaid in Mound Bayou, Mississippi. So this conversation about what we now term social drivers, but that what does healthcare pay for is a very old conversation. So
we should, in addition to the payment, though, we should talk about the regulatory piece too, right? I mean, because you heard people talk about telemedicine before. Hospital at home is enormous. Now, some of these things have foundational requirements. You need to have cell signal, Wi-Fi, safe place to take that call, or you need to have a home to have hospital at home. Hospital at home means you meet inpatient criteria. It doesn't mean you can just get a la carte stuff at home. And there's a large appetite for the expansion of the regulatory ability to deliver all kinds of things on a payment model that makes sense at home if it works for people and their lives. But those are, I mean, as we speak now, we're waiting to see what happens. At least I missed it if it happened today or last night, but I don't think we have an extension yet, right, of the authorities that are going to expire for virtual care for hospital at home. So there are real regulatory solutions that need to be put in place. It requires that zoomed out conversation about what we want the healthcare system to look like, because the last one that I'll say one more time is, like, when I was training, the idea that you would get your hip or your knee and go home the same day, there's a zero chance I believed that, right? Or that you would get your cancer surgery, and that was it, you're done. And yeah, you're coming in for outpatient infusions, routinely at some place that's really close to your home, rather than back to the large academic referral hospital. But that's happened, right? That is here now. Our doctors own partial shares in ambulatory surgical centers and do a lot of things in the outpatient setting that used to happen in the inpatient setting. The payers, probably appropriately, are driving us to do anything that can be done ambulatory in an ambulatory setting. The natural consequence of this is a decreased number of inpatient hospital beds. We're not really having that conversation. We have that conversation when the cover of the newspaper says, "Can you believe they're closing a hospital?" Well, yes, I can believe it, because we set up a system to move everything to the ambulatory setting, and then we're shocked when we didn't have inpatient capacity. It's only because we didn't take a moment to sort of step back and understand the system that we were designing and that we were building. I'll pause. There's one more regulatory, but it's gone now.
It's all right. It's all good. Before we turn to see if there are some questions in the audience, how has the increase in value-based care programs had an impact on hospital systems that trickles down to impact emergency department boarding?
Yeah, it's a good question. I don't think it's there yet, but it's directional, but it's moving. It has moved to the conversation. It was nice to hear a comment about sort of embedded social workers from the Emergency Nurses Association. It's enormously important as a part of the care team. You can't run emergency departments, you can't run hospitals without a broad, diverse team, right? Give any one of these world-class emergency docs here a super sophisticated new age ventilator and a patient with real troubles oxygenating and ventilating, and they're very grateful to have a respiratory therapist stand next to them and help them to program this thing. Ask me to set up a rapid infuser or an A-line. I can't do it anymore, right? I need someone that can help me, on the nursing side, et cetera, et cetera, et cetera. So case managers and the culture and the idea of a value-based holistic approach is great. It has mostly been focused on avoidance of pre-acute care, right? The time before you get really sick and end up in the emergency department, and that's great. It's super not good yet at you're in the ER and you need something, right? As I said, there's sort of regulatory and payment structures that get in the way of the a la carte stuff at home, and then there's also logistics, right? Again, right, the system is built for daytime. If it's 5:02 and you need oxygen delivered to you at home that evening in order to leave the emergency department, or you need to set up your home infusion, you're staying in OBS overnight, or you're getting admitted to the hospital when it's going to be denied, or we're going to leave you in the ER to keep you safe, and then later, be vilified because we kept you for 24 hours. There's sort of not an easy winning strategy there. But the concept of value, the concept that it's a multidisciplinary team that is working on you as you're getting an exacerbation of your chronic condition, right? So that we can keep you from ever needing an acute care stay, or after something already happens and we could send you home, it just means that it needs to become a 24-hour business. And the workforce issues are much more than just are there enough staff? You talked earlier about the match, right? And people not wanting to go into a 24/7, 365 specialty where you get to miss, a third of your cups of coffee with your family, a third of your dinners with your coffee, right? And a third of your sleep, right? Because that's, we used to call it the lifestyle specialty, and now it gets called the lifestyle fallacy, right? Because you're always there. It's day, it's evening, it's overnight in emergency medicine, and for our on-call colleagues. And now we're going to ask social workers and case managers to do that in order to make sure that this churn it's a tall order.
We have time for one
Oh my
question.
God, come on, it really went fast.
One question.
I'll go
So it
fast.
can't be anyone else from Mount Sinai because you already have, see, put your hand back down. You already have a shot at him. Let's go right here, please. Thank you.
Oh, lucky me. I'm going to give you, Brendan, one that we have not talked about before, Arjun Venkatesh from Yale. We talk about the supply-demand mismatch. So Brendan before said that 40% ED visit increase in 20 years. It's 30% increase in ED visits in the last decade. At least 2/3 of that we know is of higher acuity. So more patients, sicker patients, 5-10% fewer hospital beds and hospitalizations around the country. So huge mismatch. Any other industry, you'd either have to figure out how to run the factory more productively, or you'd make the factory bigger. But we have no appetite to expand hospital care in this country because everybody gets very stuck on the cost equation, and they go to where Willie Sutton principle. Our healthcare cost problem is an inpatient problem because 30% of our dollar is spent on inpatient care. Can we flip that? Is there a narrative out there where we actually say, hold on, patients are sicker, we actually need a lot of hospital care to take care of the demand that we have out there? And what would it take for you as the CEO to build that hospital care for them?
Look, the concrete answer, my CFO was sitting here, the concrete answer is a sustainable financial model, right? We're really good at this, right? This inpatient care. We've done extraordinary things with human health, and that it is a comfort zone for the healthcare industry as it exists, much more than value-based, much more than community-based care, much more than wellness. So like a little bit, I'm missing the question, you know? Of course we would do it if there were payment models attached to it. There are payment models attached to it, but because we are, as you said, interested in decreasing the overall cost of care, we are making trade-offs, and we don't talk about them very often, but we're making trade-offs. We are deciding that we are gonna accept boarding, that we are gonna allow for inequity in healthcare. We make trade-offs all the time. We don't enumerate them and articulate them very clearly. We focus on a single issue and then sort of make it a lightning rod for a while and then focus on another one. And I'm confident, for those who don't know the guy that just asked that question, he has an answer in mind that I'm not giving him, and I'm not doing it on purpose because he's a thought leader, and you should look him up and have a conversation about that. Can I add one last thing? Because this crowd, I look out there and know that that what COVID did to them, because I know what it did to New York and I know what it did to us in particular. The idea that we are not connecting this narrative around our absolute lack of sort of understanding and planning around supply-demand capacity for the healthcare system to national security and national health security feels to me like a giant missed mark. I don't know where they're going to go when there's a terror event, when there's another infectious disease, when there is a chemical event, other than to the hospital. I don't think that happens in FQHCs, in primary care clinics. I don't. I think it happens. I think it comes to us. We have a total mismatch between a system that is running at 110% capacity and an expectation that we can save American lives when the unthinkable happens. We just saw it. It happened. It didn't change the way that we think at all. But Brandon said he was going to be the dark voice
He did,
today.
and I was going to close with a question about the most important thing you thought federal partners should take away from this conversation. You might have already answered that, but you might want to add a second thing.
Yeah. For federal partners, honestly, I think it is to know that this community is not a bunch of emergency docs that are here pounding their fist on the table about ED boarding. These are folks that can see the failed social policy and the chinks in the armor for the healthcare system and can help you to find not a magical silver bullet, there is not one, but a matrixed number of incentives and structural changes and financial incentives and transparency, et cetera, that can get us to a place where we have a healthcare system that we're proud of. Our artist over here has been, I was watching him draw, and someone said earlier, and he wrote it in big letters, this can't be the U.S. healthcare system. And I think that that there is an enormous opportunity to tap the folks in this room and beyond that are focused on carving out a really, really innovative, thoughtful, cutting-edge, brave new way of delivering healthcare that is sensitive to the fact that we need to have just-in-time efficiencies where it's right, but just-in-case planning because, just because we have the high hopes and best intentions for what the future looks like. Those of us who need to have plan A, B, and C as we stand at the foot of the bed know that we might want to keep thinking about what could happen.
Please join me in thanking Brendan Carr for joining us today. I'm going to invite the next panel up to join us. We're going to do a little furniture rearranging while we're talking. It is my pleasure to introduce the moderator for the next panel, Dr. Laura Sessoms. Dr. Sessoms is a national leader in primary care health policy and the implementation of advanced primary care. She became the Agency for Healthcare Research and Quality's Chief Medical Officer in 2022, and before that, she was the Chief Care Transformation Medical Director for Value-Based Care at Anthem. And while serving as the Director of the Division of Advanced Primary Care at the Centers for Medicare and Medicaid Innovation for 5 years, she oversaw the development of a comprehensive primary care initiative and then developed and implemented the largest multi-payer initiative in primary care payment and delivery redesign. So Laura, I'm going to turn things over to you.
Thank you, Robin. Let's see. Good morning. Welcome to the panel on the myth and matters of ED boarding. I want to just start by taking a moment. Oops, we're short a chair. Peter, why don't you just come right here?
I didn't hear the applause, so I didn't.
To talk about what we've heard so far. I'd say the consequences of ED boarding can be dire. We've heard that. We've heard increased mortality, morbidity, length of stay, cost, patient safety gets worse, and patient experience falls. Vulnerable populations, we've heard about the elderly, kids with behavioral health diagnoses are at a greater risk of negative outcomes. We know, too, this is a really big problem. There are 145 million emergency department visits annually, so this can affect many people, including, as we saw, those in the room. And the problem is long-standing and worsening, both during and after the pandemic. Did you know there was a 2007 National Academy of Medicine report trying to work on this problem? So, as we've heard, too, this is not just the emergency department. This is health system breakdown. The emergency department is a window into the health of the community's health system. And as you can see, I think that our fabulous graphic artist has drawn, the entrance is always open and the exit is frequently blocked. It's an output problem. It's a system issue manifesting in the ED. It's a disease with the ED boarding as its symptom. People are admitted to the hospital on paper but can't be transported there because there's no room, so they wait. This seems like a simple numbers game. Maybe we just need more beds. We've heard that at least Mount Sinai can build them, but it's a numbers issue. But we know nothing in healthcare is simple. So how do we make it easy to do what we all agree is the right thing? I'm pleased that at this point, the panel is going to be, that we have here is going to talk about solutions, and we're going to take your questions about these solutions at the end. I'm going to introduce each member of this august panel and ask each one to tell us in what year they first started working on this seemingly intractable problem. I'm going to start with Dr. Gabe Kalin here to my left. He's a professor and chair of the Department of Emergency Medicine at Johns Hopkins, and in addition to other roles, he's a director of the Johns Hopkins Office of Critical Event Preparedness and Response. Over his career, he's served in senior leadership positions in the National Emergency Medicine Organizations and has authored many papers, including authoritative papers on boarding. So, when?
1984, just like the title of the book, and it sometimes feels like it.
So a long time. Dr. Peter Viccellio is a professor and vice chair of Department of Emergency Medicine and an associate chief medical officer at Stony Brook University Renaissance School of Medicine. Much of his career has been focused on examining how dysfunctional hospital flow impacts patient morbidity and mortality, patient satisfaction, staff retention, and hospital finances. He's authored many papers and books on these topics and has spoken extensively on these subjects. When did you first start working on this?
My first article on this was in 1987, and our first, you said 2007 was your first summit?
The NAM report.
Our first summit was, and the New York Times was there, and ABC and CBS was, whatever, in New York City was in 1987. It was about the time of the printing press, somewhere around there.
A very long time. Next, I have Dr. Alistair Martin is an emergency medicine physician and assistant professor at Harvard Medical School and chief executive officer of A Healthier Democracy. Dr. Martin served in the office of Vice President Kamala Harris at the White House as a White House fellow, where he worked on health policy. I realize you are more junior, and when did you start working on this problem?
I think I'm here to bring the millennial approach. It involves lots of Instagram and TikTok. I would say 2015.
Okay. Dr. Vicki Morton is a community emergency physician in Florida and has served as a clinical affiliate assistant professor for Florida Atlantic University since 2001, and we are especially grateful she's here today because of what is happening there. Because of her firsthand experience of treatment of emergency physicians employed by private equity-backed contract management groups, she became more involved in the American Academy of Emergency Medicine to work on change. She's now the president-elect of that organization and also serves as the vice president of her county medical society. And when did you start?
Thank you so much. Imposter syndrome is real. I have not been working directly on this issue, but as we've said that this is a symptom of a much larger problem, the issues that I've been working on, this is a symptom of, and I would say I've been working on them since probably 2019 when my kids were old enough to all be in public school and I had more time.
Last but definitely not least, Dr. Jesse Pines is the Chief of Clinical Innovation at U.S. Acute Care Solutions, and in this role, he leads efforts in alternate payment models, telemedicine, research, artificial intelligence, and other innovative programs. Dr. Pines is also a practicing emergency physician and professor of emergency medicine at Drexel and a clinical professor of emergency medicine at GW. He's authored many published papers and books, including authoritative papers on boarding. And when did you first start?
I started working on this in 2004, and along with Dr. Bicellio, spent many years doing publications around crowding and boarding. So very passionate about this issue.
Before the panelists begin, I want to give you a quick framework that might help those who are new to this problem think about the solutions you will hear described. So I'm a general internist. I'm a primary care doc. And in my clinical practice, my goal is to keep patients out of the ED. So I am relatively new to the ED work. And in thinking about it, I see there are really 4 big areas that we need to work on. It's the location of care. There's special circumstances that need focused solutions. There's the problem of who's delivering the care, and last but not least, payment and regulation about the care. So in terms of the location of care and its effect on boarding, we've heard talked about today. There's downstream issues such as urgent care. Do we have high-quality primary care? What about emergency medical services? What about overall patient complexity? Yes, they definitely affect crowding and indirectly could affect boarding, but they are not the direct cause of boarding. Similarly, what's happening in the ED? Can you get specialists to consult on patients? And how well are you doing on throughput? That's a crowding issue. It is indirectly can affect boarding, but it is not an output issue. Where the problem of boarding occurs is upstream. And so what happens when patients need to get out of the hospital? Again, the door to that hospital, as our fabulous artist shows, is partially blocked and they can't get out. So that problem is what's happening inpatient. How efficient is the care? How efficient is the discharge? What's happening outside of the hospital in post-acute care, rehabs, nursing homes, et cetera? And then what's happening if patients need to be transferred out of that hospital to another one, or if they're in an ED and need to be transferred to a different hospital? And do you have transport, and are you getting acceptance for that? And then there's in addition to location, there are the special circumstances that will need folks' attention. Behavioral health and rural are 2 really big issues. Some of you may have heard that a patient in Maine, a 13-year-old with behavioral health issues as well as others, was finally discharged this weekend after, wait for it, 304 days in the emergency department. So it was a rural issue, a pediatric issue, and a behavioral health issue. So in addition to those special circumstances, the third bucket is who's delivering the care. We have heard over and over today about burnout, moral injury, and the decline in pipeline. Those in the emergency department suffer, but they cannot solve this problem. They cannot solve it alone. This impacts particularly ED physicians and nurses, as well as anybody else that's in the ED. It also, though, we need to think about the pipeline for nurses and all the other clinical staff in the hospital and outside the hospital who are staffing nursing homes and the other places where patients may go after they leave. And last but not least, there's payment and regulation that more and more drives what care is delivered. We want efficient, lean care, but what does that do? Do we need elasticity? Do we need redundancy? What is the effect, you've heard this question, of value-based care on all of this? On bundled payment, of prioritization of certain conditions that then leave the others less focused on. And we've heard about higher payments for procedural and lower for cognitive care and behavioral health care. So those are the problems, and we are here today to harness the knowledge, expertise, and passion in this room once and for all to turn this problem from intractable to solvable. And with that, I'm going to turn first to Dr. Kalin and hear from him about some overviews of strategies that perhaps have been tried and failed and where we can go for successes in future.
Thank you. So it's not solvable. Who's speaking next? So I want to make a couple of comments up front. We really need to reframe this message and the strategy as to how we go about nationally fixing this. You've heard how long some of us have been working on this. There have been exposés over the last 30 years, New York Times, Wall Street Journal, USA Today, Time Magazine, Newsweek, ABC, NBC, year after year after year, the press decries how awful this is, and nothing happens. Art Kellerman famously said 30 years ago, the ED's in crisis, we need help. But the response is, well, the ED's always in crisis, so here it is 30 years later. The sun still rises and the sun still sets. So crying crisis, 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 harm, 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 in and of itself doesn't seem to get any purchase, thus far anyway, with anybody. So the elephant in the room, as Dr. Carr mentioned and others alluded to, is healthcare financing. If you were to run a business that got margin at best of 2%, what would you do? I mean, hospitals are running as if they were grocery stores or gas stations. And that 2% isn't even enough to plow back into maintenance, let alone new programs or solving a healthcare financing issue like this. So you get huge misalignment of incentives where the CEOs have to preference high-paying patients, which usually means procedures and surgeries, over those that don't have it. And the vast majority of patients coming through the ED are not high-procedure patients. Some are, but not enough. And so the preference is, and you really have no choice. My ED is subsidized. My ED is subsidized because surgery is able to make some money, and I get that to help subsidize my department. Actually, I call it underwriting. I don't like the word subsidized. But there's a reality to the way healthcare is financed. Cognitive specialties make almost no money. By the time you add up their loans, they can't make a living. Psychiatry, internal medicine, pediatrics, these people can't make a living anymore, even though to the rest of the world, it seems like they're making a decent salary. Surgeons, interventionalists, you can make a lot of money. If you don't have a procedure, you're not going to do well in healthcare. I surveyed a couple of years ago, some of you are in this room, all of the members of the AACEM, that's the Chairs Association of Emergency Medicine, and asked them, have you any sustainable solutions for boarding? Not one said that anything that they had ever done led to sustained changes, even though many had short-term successes. Not one. And all of them said that despite all the changes that they made, boarding is either the same or worse. So that's my doom and gloom. Solutions. If the CEO or the chief of your board of trustees isn't into trying to solve this, you're dead in the water. Your CEO has to be the lead of trying to solve this. 12 years ago, I took this issue to our board of trustees and presented it. And the chair of the board of trustees was totally aghast, because all board of trustees normally hears is how great every department is. And I told them how terrible boarding is and that we're harming people. put together a huge committee. He held the presidents of our hospitals' feet to the fire, meaning their salaries were dependent. The hospital presidents kept the chairs of various departments' feet to the fire, and their salaries and bonuses were part of this. And oh my God, within a couple of months, almost all our boarding issues went away. And then slowly it crept back, because the amount of effort that everybody had to put in was not their normal type of effort. And people started to complain. Ophthalmologists said, what do I have to do with ED boarding? Even though we have an ophthalmology service that keeps patients there for a long time at times. So eventually it just all fell apart, and then boarding became worse. But the CEOs were no longer held to the metric that you're going to help solve this problem. And the chairs were relieved of their salary obligations to make this work. So the CEO has to buy in. We heard about the other solutions very quickly. The 24/7 hospital. Yeah, people don't want to work weekends other than us, and intensivists maybe, hospitalists sort of. The 24/7 hospital really would work. Surgical smoothing, we tried it, it actually works. Surgeons don't want to do it, maybe 1 or 2, but you will not get your surgical group to want to do this. They train 5-9 years. They want whatever tiny part of their weekend and Friday afternoon off if they can get it at all. Remember, they still come in Saturdays, Sunday morning to see their patients. Some things that do work for the few hospitals that have managed to get their discharge time to match the admission demand side, that works. Very few can seemingly achieve this. Surgeons are not too bad at discharging patients between 10 a.m. and 2 p.m. Medicine seems totally incapable of getting any proportion of their patients discharged in the morning. Some stuff that we can do, we formed an aftercare clinic. Emergency medicine formed an aftercare clinic so that instead of admitting some patients and patients who couldn't go anywhere, we could send them the next day to a clinic where all of their care and subspecialty stuff could be coordinated in a different time frame. Eventually got taken over by internal medicine, and it really is one of our great successes. Another is care maps. We have over 100 care maps. The big ones like syncope, chest pain, CHF are specifically designed to keep our practice uniform with very clear guidelines, who gets admitted and who doesn't, and all of the services have agreed, and whatever risk is inherent isn't really there, because if you're following the guidelines, you mistakenly send somebody home, you followed standard of care, you followed the Hopkins protocol. We have to have regulatory agencies keep their own rules. The Joint Commission has a 4-hour rule, right? The Joint Commission came by, and we have people vomiting all over the floor of our waiting room, and people rolling around. There's urine everywhere. Every hallway is full. And then they cite us because the refrigerator had a 1/4 of a degree off. Like, does that make any sense to you? And they just walk by all this stuff. And in their own memo, they says, we can't adhere to the 4-hour rule because nobody can seemingly meet it. So why bother? Why have a regulatory agency if they don't bother to do this? A bed czar, that actually works. You know, there are bed games. There are some proceduralists that hoard beds until late in the day just in case they might need an ICU bed. But so you might have like cardiac, like we do. They might hold 6 beds, and even though one of the patients that they've operated on actually needs that bed. But a bed czar can just place a patient in whatever is the next right bed. A couple of novel solutions I'm going to suggest. One is to expand the scope of emergency care into inpatient the first 3 days of acute decompensated care. We're psychomotor activists. We already take care of patients during those first 2-3 days. Several years ago, I challenged the institution to give me an inpatient bed, and inpatient unit, and they gave me one. 4 buildings over, 6 floors up, and we ran it as an observation inpatient unit. We make decisions quick, fast, get people in and out, and it worked great. Then they built a new tower, and we no longer had our inpatient unit. They gave it to somebody else. But that actually worked, and we ought to consider within our own field claiming a whole new area. Another thing to work on is end-of-life care. You talk to our intensive care specialists, and they tell us the ICUs are full of people that are virtually futile. And other people, as we heard, are dying who have a much better chance of living than the people who are just moldering, I guess. I don't really know what the right term is. Okay, a couple of things that don't work, just in the interest of
Real
time.
quick round.
Yeah. Building a larger ED. I'm famous for this quote. You can't cure constipation by building more colon. So a larger ED is not going to fix boarding. Keeping low acuity out, I'm sorry, I don't want to hear it. Low acuity patients have nothing to do with boarding. At times, you may argue that they contribute to crowding. And I'm going to disagree with my colleague, Dr. Carr, about the model of input, throughput, output. Input and throughput forces the conversation in the wrong place. We have to concentrate all of the conversation on the output. Building an urgent care nearby does not work. It actually increases ED volume. We've built an urgent care nearby one of our hospitals, and our volume went nuts. Not only that, when you build an urgent care nearby, they take away all the paying customers because they're not bound by EMTALA, and they leave you with all the people that they don't want to see, and now you have even less money to manage the emergency department in the hospital. Ambulance diversion doesn't work. Physician at triage is really nice to decrease your risk, but it doesn't help with boarding. Inpatient units coming down, that's kind of nice, doesn't help with boarding, doesn't actually get them up. And stopping electives is usually too late. If you have a surge plan, it has to be preemptive. ED volumes and boarding is highly predictable. So if you have a surge plan, it's way too late. You're bailing the boat while it's sinking. You have to be preemptive, but I don't know a single hospital that invokes a surge plan in a preemptive way. Thank you for letting me go over it a bit.
That was a lot, but some great ideas. I'm not going to let the panel give reactions to that, but because they're all going after you, so they can do it while they're talking. But I'm going to turn next to Peter Vicellio to my right to talk a bit about a hospital-wide approach and throughput and surge capacity.
So I want to tell a story because I think it's an important story to understand why we are where we are today. Everybody's familiar with the story of the frog in the water, where the water is slowly heated until it's boiling and the frog dies. I'm a little kid back in the 50s. I go on house calls with my father. Heart attacks, strokes, heart failure, those sorts of things were treated at home. There was nothing the hospital was going to do for them. So the hospital was filled with people that were getting cholecystectomies or ortho cases, or people, but they had bad infections that needed IV antibiotics would be in the hospital. But your hospital capacity was 60, 70%. Length of stay was maybe 10 or 12 days. And it made sense to maybe just do surgery, elective surgeries on Mondays and Tuesdays. It made sense to have a 9 to 5, Monday through Friday, with a skeleton crew on evenings, nights, and weekends, because there really wasn't, the population there wasn't that bad. So let's start to let the heat simmer a little bit. The same thing was true in the 70s. At the end of the 70s, hospital capacity started to hit. When I started in emergency medicine in 1980 at Booth Memorial Hospital in Queens, there was a 10-bed unit behind the emergency department called the death trap. And that's where admissions went. That room had been there for a good 5 to 10 years, which means that room existed before emergency medicine existed, which also means the emergency department was not part of the power structure. The emergency department was not part of this is okay, this is not okay. So there was just mission creep. And when you start to board patients in the emergency department, what does it look like? It looks like you're crowded. If they're not boarded, what does it look like? It looks like you're crowded. They had defined rules upstairs. There were no rules in the emergency department, nor was there anyone to represent them to try to make those rules. So if you look at our system today, where we have a 7-day-a-week problem that we're trying to solve with a 5-day-a-week solution, that 5-day-a-week, if you take it 8 hours a day, because even you commented on weekends and nights being a bit slim, that represents 24% of our week. And I'm going to tell you that it's actually worse than that. We published a paper looking at 1.6 million admissions to New York hospitals. It was from the Sparks data. And we looked at what the mean census per day was in the hospital and how it fluctuated across the week and why it fluctuated across the week. And almost all of the fluctuation was due to elective admissions, which I would also say schedulable admissions, which also means admissions that you can control when they come in. And it was, if you compared it to the mean, the peak was 20% above at the beginning of the week to 30% below at the end of the week. So, and it really, if you looked at just elective surgery, the curve for elective surgery, it looked like we're talking about, going from 5 to 7 days a week. No. It'd be nice if we could go from 3 to 5 days a week, because most of the surgery is done in the first few days. Now, there was a slide.
Can we get the slide up? We'll work on that.
Yeah, this happens in every damn emergency department in the United States of America. You need to fix this problem in the emergency department. You're crowded, there's long waits. So what are we going to do? So here's data from one emergency department. Arrival to being seen by a healthcare practitioner, 25 minutes. CAT scan from order to read is 267 minutes. And door to inpatient is 975 minutes. When you look at these numbers, what should you work on? Anybody? Chime in. Well, which one of these has a metric? Which one of these do outside agencies reward you for having a good number? It's the arrival to healthcare practitioner. So this is what I call putting lipstick on a pig. We do it in every single institution across the country. Is you tackle the little thing, everybody can get their little QA award, and it hasn't made a bit of difference to the larger picture. You want to get rid of left without being seen? Everybody wants to do that. Why do you want to do that? Because it's a good goal. But you undermine that goal with a metric, and the metric is what's your percent of people that left without being seen? So if what I want to happen is for that patient to be seen timely, and hopefully the number gets better. But when you solve that by putting a PA or a physician at triage so they can shake their hands, I've seen you, so now I've captured you in my vision. You can't leave without being seen. Look, I'm at 100%. I'm perfect. So that's what we do. So, boy, I could just keep talking forever. But I have some solutions to propose, but I want to warn you beforehand about these solutions, please. Because everything is always, we got to build more and we got to pay more and whatever else. These suggestions do not require that people work harder. They only require that they work differently. They don't work longer. Most of these solutions don't involve weekends. They don't involve evenings. They do involve the hospital making a lot more money if they do this. They do involve the physicians having a bit easier work schedule if they do this. It does result in better nurse retention, less nurse turnover, and less overtime. So is anybody interested in this at all? Okay, so we got a few people interested. So the first thing is smoothing of elective schedulable admissions. This does not mean smoothing over 7 days. All the work that's been done on this has been on a 5-day schedule. And if you look at the data on this, you got a lot of OR time on that 4th and 5th day. So in one institution where they did surgical smoothing, and it's in a couple of steps. Step 1 is you separate out the emergent care from the elective cases. And you dedicate a couple of ORs to the emergent stuff, but all the rest is elective, so you can fully schedule it and it can be predictable. They're not competing with each other. So in this one institution where this was done, if the year before they implemented smoothing, now think of this from the point of view of the surgeons, they had 776 cancellations or rescheduling of cases. That's 2 a day for a 365-day year. The year after they had surgical smoothing, for elective cases, they canceled 6. 776 versus 6. So I think that would be arguable that that's a benefit. Children's Hospital in Cincinnati, they were having a problem with boarding. They couldn't take tertiary and quaternary transfers. They had boarding in the emergency department. How do you fix this? You build a 100-bed tower. They're in the middle of doing the architectural drawings for the tower. During that time, there's a fellow named Eugene Litvak who's with the Institute of Healthcare Optimization. He's the main maven for doing surgical smoothing. And you're smoothing not to number of cases a day. You're smoothing to number of inpatient beds needed, and you're smoothing to the number of ICU beds needed. That's the smoothing that you're trying to do.
About one more minute.
Okay. Anyway, with that smoothing, it resulted in canceling the building, which they subsequently built 15 years later, and with the same surgeons and the same number of ORs, they were able to do $130 million more in business. 2 other things I will mention real quick because of time and I've talked too much. Early discharges, NYU, the CFO went to the CEO saying, we have noticed that if a patient goes upstairs afternoon, if they're admitted and they get upstairs afternoon, their length of stay is a half a day longer. You got to do something about this. So the CEO told the chief of the hospitalist there, and he did 2 things which were very important. You're in single digits. You need to get your hospital discharges by noon to 30%. There was a target, not getting better, but there was a target. And you got to do it within six months. So there was a timeline as well. That resulted in an O to E drop of 0.8. Weekend discharges, Montefiore was boarding 30 patients a day on average in their emergency department. The executive VP there decided to attack weekend discharges, enhance weekend discharges to the tune of solving the boarding problem and actually closing a 30-bed unit for a while because they didn't need the beds. And the last thing I will say is all the things that happen within the hospital. If you have services that are there from 9 to 5, what happens, how many of those wait the next day for the service? We found that if you ordered an echo somebody, their wait increases the length of stay by a day and a half. You have 10 echo techs there, they come all in at the same time. Do you need to hire more techs for the evening, or you just redistribute your staff so that you decrease the number of queues? And you multiply this across everything that's done. You did the story about the MRI in the emergency department. My resident did a research project which was the following. If we call neuro as a consult and they say you need to get an MRI, how long does the patient stay in the ED? And it was for an average of about 16 hours. But he also said, what if the same thing happens on the inpatient service? And from the time of calling a neuro consult to finishing the consult was an average of 5 days. Because if it's not an urgent consult, the neuroconsult can come the next day. The MRI gets done the next day. It gets read the day after that, and the neuroconsult finishes. So back to Gabe's saying, if the inpatient service thinks like us, I want the test now, I want the results now, I want to act now, I think these would have profound impacts on length of stay. Sorry.
That is amazing. So we've gotten some incredible solutions that have worked, and there is actually data to support how valuable these are, and financial savings also, which is great. I'm feeling more positive.
But only millions and millions and millions.
But now I'm going to turn to Alistair Martin, who's going to talk some about behavioral health issues and vulnerable populations.
Fantastic. Thank you so much to my 2 esteemed colleagues. I'm going to try and be brief here. You know, I think that to begin with, the idea of asking ED physicians to address the ED boarding crisis, it's a little bit like asking us to rearrange the deck chairs on the Titanic. And not only have we, but we built lounge chairs. I want to start with the myths, because I was asked to bring some of the myths, some of the things that maybe we should look at, but ultimately rule out in terms of interventions that we ought to consider. If we can share the slides. I want to share you a story about our hospital up at Mass General ED. This is our data. All credit to our incredible CMO, Josh Bow, for putting this together for this. What you're looking at on this slide here is a period of time between March 2021 and March 2024. We did a number of things at Mass General Hospital that were aimed at trying to address this problem. We did a number of things aimed towards decreasing ED admissions, like increasing our ED observation rate, expanding ED obs units. We built one of the most impressive home hospital interventions across the country. We increased transfers to community hospitals. We work in a health system of 4 or 5 other big hospitals where we can admit a patient to another hospital within our health system to divert patients away from being admitted at MGH. And we increased our discharge rate from the ED. Subsequent to all that, what we found was a drop between 29 to 21% of ED admissions over time. Over the course of the same exact 3-year period, we saw a doubling of our boarder rate. We rearranged the heck out of those deck chairs. And so what I want to focus in on are a couple of solutions that we begin to see out there that might be the sort of like the shining lights that if we put a little bit more emphasis, we might find evidence to increase the impact of these solutions. The first is actually the federal government. So we're still in the midst of one of the most impactful and concerning problems, and that's the opioid epidemic. And while rates have decreased, opioid overdose deaths have decreased this year for the first time in about 10 years, we still have a tremendous number of folks who are dying every single day due to the opioid epidemic. And that's also increasing the number of folks that we need to see in our emergency departments. So during the COVID pandemic, we expanded pandemic-era flexibilities to allow for folks to get access to things like buprenorphine via telehealth. So now patients who are struggling with opiate addiction could get access to medication for addiction treatment using a telehealth visit. They didn't have to come to a primary care doctor or come to the emergency department. Well, on December 31st, 2024, those COVID-era flexibilities are going away. All of those patients who were getting treatment for buprenorphine for opiate addiction, they're all going to find that they're going to drop off a cliff at the end of this year. And where are those folks going to go? Many of those are going to show up in our emergency departments, and they're going to increase the number of folks that we're going to have to take care of in our emergency department. And we'll do it as ED docs. We will step up and we will deliver. But for the federal government, both SAMHSA and DEA have the administrative abilities to extend those COVID-era flexibilities. The second group that I want to highlight are folks with mental health issues. Do we have any folks in the room from M Health Fairview from Minnesota? Okay. Have folks heard about the incredible work that's happening with empath units in Minnesota? So I want to share a little bit about what's happening at M Health Fairview. So what they're doing at M Health Fairview is building a second sort of an auxiliary place to address patients who are coming in with psychiatric issues. So a patient will be evaluated in the emergency department and then transferred to a separate unit, an empath unit. And this unit doesn't look like a hospital room. It looks more like a living room. It'll hold somewhere between 15 to 25 patients. It's a much decreased area for care, less noise, less stimulation. And what they find is over the course of 24 hours in this empath unit, folks not only do not need to be admitted to psychiatric facilities, what they find is that over the course of 24 to 36 hours, they can be discharged from that unit, thus decreasing the rate of folks who need to be admitted to psychiatric hospitals after that. So there's a couple solutions that we might be able to look at.
That's great. Thank you very much. Now let's turn to Vicki Norton, who will talk a bit about workforce. We've talked about that as another major bucket of issues here in the boarding crisis, smaller healthcare systems, and rural issues.
Just a couple of topics in 7 minutes. Okay, well, in talking about workforce issues, I think one of the biggest myths regarding workforce strategies to fix ED boarding is that the workforce can somehow fix it, which we've heard over and over again here today. It's not happening. The workforce is not going to fix this problem. But I think that we have to recognize what's the underlying issue with that. And the biggest issue, and we've touched on it a little bit, but I'm going to kind of go there. I'm going to go there and I'm going to be radical and I'm going to talk about it. We have a problem of prioritizing profits in our healthcare system. And part of that is because we've let non-clinicians and business people kind of steer the ship. And it happened decades ago where we kind of said, well, maybe doctors are, costing us too much money in how they run healthcare, and we need to start putting other people in charge. And we had HMOs in the 80s, and we had, other iterations of that since then. But we've really gone off the rails in the last decade or two, and that's with the introduction of private equity. I think one of the big myths is that you think your doctor can speak up for you. It's not happening. Doctors are not able to speak up for their patients. They don't have due process. They're working for third-party contract management groups that are backed by private equity, and they're signing away their due process rights. So when they try to bring up a problem about boarding in the emergency department or try to bring up a problem about understaffing, they're fired for it, or they're written off the schedule. Oh, and guess what? You can't even stay in your area by your family in your community because you also signed a non-compete in that contract. So these are issues that we have to address within the workforce in order to help combat these issues in the healthcare system overall. And I think that if we can do that, and if we can get due process for physicians and allow them to speak up for patients, we're going to have more events like this and more opportunities where we can come together and find real solutions to the bigger disease. I know that we've talked about burnout a little bit and moral injury, and I would say it's even worse for our younger colleagues in the emergency department. A lot of them are graduating from residency programs and are already looking for an exit plan out of clinical medicine. Our average age of leaving emergency medicine, I think, is in the 40s. I think I'm a year overdue to retire at this point because women leave emergency medicine earlier than men. So we have a major workforce issue, and just putting it on us to fix it is not going to help. Having more doctors, having more residency spots, matching more ED residents is not going to fix the problem until we address why aren't people wanting to match into emergency medicine. So I think that's one issue we need to look at. And in terms of staffing shortages, it's really a resource allocation issue, right? There's never a lack of staff for an OR. It's a resource allocation problem. We need to prioritize emergency care the same way we do elective surgeries and procedures. So if we can also have some parity in terms of how we're reimbursing, that might help the situation. And then in terms of talking about smaller hospitals, so we've seen how our healthcare system has gotten completely over-consolidated. It's been over-corporatized. Smaller hospitals, I think, sometimes are at a disadvantage because they have less beds and less resources, but they have the advantage in terms of being community-based, maybe being more flexible and responding to the needs of their community. If the health system takes over and it becomes more consolidated, you might have more resources in terms of being able to transfer patients to satellite facilities and things like that. But then it also becomes like a one-size-fits-all solution to problems that happen within the system. And so I remember a study I was looking at from Annals of Emergency Medicine in 2018, by Chang et al., was looking at, well, let's look at these hospitals that are the best performers in terms of boarding. Let's look at these hospitals that are the worst performers, and then let's look at the ones that are the most improved. And they looked at a ton of different interventions on how these hospitals tried to address the boarding issue. And there was no one intervention, as we've heard here, there's no one intervention that across the board made the best hospitals the best, or the most improved the most improved. What did happen, what they did see in terms of the best hospitals, was that the ones where there was an organizational culture around recognizing this as a problem and addressing this problem, where there was executive buy-in, nursing leadership buy-in, where everybody was working together to provide systemic change, that's where they saw a difference. And then in terms of rural healthcare, we really have to help our rural communities. Rural patients are having more delays for care, longer boarding times than at other hospitals. And this is going to affect their quality of care. I can give you an example from a colleague of mine, and I hope I'm not running out of time. A colleague of mine works in rural Washington State, and she had a patient come in with a non-STEMI, a heart attack. It wasn't one of those heart attacks where you go straight to the cath lab kind of thing, but she needed to go to the cath lab sooner rather than later, and was waiting to be transferred to a tertiary care facility that had a cardiologist and a cath lab that was able to take them. She waited in the hospital for a week. She waited so long to be transferred that she ended up signing out against medical advice from the rural facility and going home. And then she bounced back a short time later in severe congestive heart failure and ended up going on hospice and passing away. And this was a completely preventable death. This was somebody that should have been able to get the care that they needed. So in that actual scenario, the cardiologist came up with a solution and leaned into this problem and said, how can we help you? And they designed this whole out and back for procedures, so that patients now, if they need like just to have a cardiac cath, they'll be transferred to the facility that has the capabilities and then transferred back. And same thing for like an ERCP, if they have like a choledochal lithiasis, if they have gallstones in their liver, or for a urologic procedure, if they need a stent for a kidney stone, they can transfer the patients out for the specialist care and then bring them back to the rural facility, which honestly the patients like better too, because as you heard, you're sometimes transferring 500 miles away or out of state, and the patients don't want to be that far away. So this is one solution. Another thing is that rural hospitals need more access to specialists, and whether that be through telephone consultation or telemedicine. The telephone consultation is key. A lot of specialists are just burnt out. Like the demand for specialists far outweighs the supply that we actually have. So they're covering too many facilities and they're getting burned out from that. And then they don't have malpractice coverage for telephone consultations. They don't have reimbursement for telephone consultations to these rural facilities. So we have to look at those as potential solutions too, in order to get these facilities access to the specialists that they need. And we need to increase residency spots in this country. Like we've had a freeze on residency spots for multiple specialties, not in emergency medicine for some reason, but in multiple specialties, and we need to really get more federal funding for more residency positions for specialists. So I think those are some potential solutions for rural hospitals, and I think that overall shifting our culture and dealing with the elephant in the room, which is the corporate practice of medicine, allowing lay owners to determine how we practice medicine, is something that we really have to examine as a specialty and as a healthcare system.
Vicki, thank you so much for those many solutions, and most importantly for speaking the truth as you see it. That's great. And then last but not least, we have Dr. Jesse Pines, who's going to talk about the financial drivers that we have heard are really driving a lot of this problem.
Great, thank you. So, again, we've heard from several people today about some of the financial drivers of this. I'd like to offer an analogy here. So ED boarding is a lot like climate change. One, it's clearly a problem. Ask the folks in Tampa or North Carolina today. Two, it's undoubtedly worsening. We've seen a lot of evidence of that so far. And then three, perverse incentives really exist to perpetuate the causes. And then 4, there are solutions out there, but those solutions are difficult and they're not broadly implemented. So first, let's talk a little bit about the data. There's been data over 20 years to demonstrate that ED boarding and crowding is associated with worse outcomes. Imagine going into the emergency department, getting admitted at the inflection point of an acute illness where your care is basically on pause for 6 or 12 hours. That's the problem. Patients are not getting the care in the emergency department, the same level of care that they get on the inpatient floors, and we shouldn't be surprised that when that happens, people have complications, there's higher mortality. Second, I think we've heard a lot today that boarding is a fixable problem. I'm going to say it again, boarding is a fixable problem if the wherewithal is there to do it. And you heard from Gabe, if you put the incentive out there, it's fixed overnight, right? It's fixed, but really what it takes is leadership, it takes time, it takes energy, and it takes sustainability, and also it takes the willingness to make trade-offs, because if you are making more money from elective patients than you are from ED patients, it's very easy to just to sort of let it go. It's also a problem that's really worsening. I work for U.S. Acute Care Solutions. We staff over 300 emergency departments across the U.S. Looking at our data on boarding, using a baseline of 2019, there were about 2,500 hours per year per hospital, which was our baseline in 2019. Now we're about 6,500 hours per hospital per year. So it's about 2.5 times worse across the country. We staff about 10% of the nation's emergency departments. We've talked a lot about the perverse incentives. Cancer admissions make more than the 85-year-old patient with pneumonia or heart failure in the emergency department. That is really, I think, one of the underlying issues. But also, to hospitals' credit, hospitals don't really want to have a dysfunctional emergency department. So, it really is in hospitals' best interest to fix it. But the problem is it's easy to neglect because the incentives are not there to really make it a priority, because, Dr. Carr, he has 10 different priorities as the CEO of a healthcare system, and he's going to focus on the ones that really bubble up to the top when it comes to making sure that the ship is running, right? And that's around the financial sustainability of a business that has a very small profit margin, 2%. That went underwater for a short period of time during the pandemic, and a lot of what hospitals did, because they were spending a lot of money on nursing staffing agencies, is that a lot of hospitals downsized their capacity and just focused on W-2 folks who they could actually keep in the hospital. So I've got 5 different ideas for how we sort of change some of the perverse incentives. And again, these are ideas that I think we've heard some of these today. The first is very basic, is just to make sure that boarding is measured and publicly reported. Dr. Venkatesh there can attest. There's a measure that has boarding as part of it that Yale is developing on behalf of CMS. The boarding is a very easy thing to measure, so it has to be out there, and it has to be out there publicly and part of a hospital's reputation. 2, it has to be a centerpiece of value-based care. In particular, it has to be part of incentives that hospitals get or don't get when it comes to bonuses or even penalties. It should also be in the Medicare Stars program. It was for several years. It was in there. It was taken out. It's about the sustainability, because you can fix it for a short period of time, but it really needs to be built in to the fabric to be durable. Third, and I call this the thermonuclear option, CMS and other insurers could decide that they're not going to pay for patients in the emergency department until they get upstairs. So patients are not receiving inpatient level of service in the emergency department. The inpatient payments could start when the patient goes to the inpatient floor. That would immediately change a lot of the incentives around boarding. Fourth, as Gabe mentioned this, around Joint Commission and the patient flow standard, which has been around since 2007. When they come into the hospitals, they don't really focus on that at all. They don't enforce their own standard. And then the fifth area that I think that CMS could focus on areas like conditions of participation and EMTALA, using existing laws that are on the books to really leverage and really enforce some of the rules around boarding. So again, boarding is like climate change, but unlike climate change, it is a more achievable problem. I mean, there are tractable solutions out there. Climate change is thankfully, a much more difficult problem. Boarding is a solvable problem, but it really takes leadership, both the hospital level, and I think the message for this audience, the government needs to do something. Urgently needs to do something to fix a lot of these perverse incentives. Thank you.
Yeah, so this is amazing. I feel the passion, the stress, but also the possibilities. I want to let the panel very briefly give a reaction if they have something that they feel like they need to say, but next up is audience questions, so just go ahead and get ready with your questions.
Jesse, your comment about government intervention, I wanted to expand on that a little bit. The things that I had described about, which basically requires that people do their day differently or schedule surgeries differently or whatever else, the problem with leadership in the hospital is that if I'm a CEO and I start telling the surgeon what to do, then I'm not the CEO there anymore. But if, for instance, an outside government agency, or regulatory agency says you have to do this, then as CEO I get to say, it's not my fault, Daddy's making me do it. And I think it's a way of forcing this stuff to get implemented without costing people their jobs. And so I think that would help move it forward. I don't know if people have a negative opinion on that.
You're talking about giving cover.
Yes.
Unless we're very clear, government intervention can get this really wrong. In the state of Maryland, they formed a commission to look at ED boarding. And they came up with 2 measures, and one of them is the one that you showed, which is time to discharge. And I'm thinking, you gotta be friggin' kidding me. That's not the issue. How can I discharge a patient if they're waiting and waiting and waiting for a definitive evaluation? And the only way that they can get a definitive evaluation if I can put them in the right type of bed. So it's absolutely amazing that despite emergency representation on this commission, including from my own hospital, of very knowledgeable people, that they're coming up with one of these totally nonsensical, unrealistic, useless measure that we now have to actually meet, or the hospital loses money. And so the CEO is putting pressure, rightfully so, on us, meaning us, the ED, to fix this problem instead of the actual boarding problem, which would help fix this problem. I have one comment. I'm encouraged by our hospitalist person who is here. Thank you. We should ally with our hospitalists, intensivists, and our surgeons. Our surgeons are frustrated they can't get their cases through. Intensivists are frustrated because they can't get their patients to the floor. And our hospitals are frustrated because they can't get their patients to rehab and nursing homes. We are not the only ones. And I think if we expand this umbrella to other members of the hospital, then that will help take the heat off. This is an ED issue.
Anybody else? 30 seconds before we go to questions. Okay. All right. It's your turn. Any questions out there?
Thank you. Another very interesting panel, so I appreciate the feedback. Something that seems like very low-hanging fruit is the throughput and the output problem is we're not really talking about is all the prior authorizations and the delays to getting the patients in the bed. So I can wait 3 or 4 days for a payer to tell me that they could go to rehab, even though I thought, and then it'll be a Friday, and then the nursing facility won't take the patient until Monday. So that's a week of delay where that patient's going to have increased medication errors, deterioration of their clinical status, and then stay longer at the rehab facility. So we should be talking a lot more about that. One other thing that's been coming to mind is this whole observation stay has been a real huge success. When we implemented OBS, it was surprising to me that the patients weren't angry at me. They were appreciative that they could get everything done in 24 hours. So my average length of stay on 5,000 patients became 24 hours instead of 5.4 days. But that shifted the focus on the efficiencies of the consultants and the procedures and the imaging to those OBS at the detriment to the inpatients. So it's not a zero-sum game. It seems to be that there's still challenges, but we've shown that we can do this. But then the hospital systems are getting paid less because the OBS stay and then the barriers that we struggled with as physicians trying to explain to patients, I'm sorry, OBS, I don't know what it means for your pay, for your cost, and, I'm sorry, I don't want to get in between you and your insurance, the payers, and what that stress test will cost you. So there's still, again, the concept of what we need to do to fix the payment models so that the hospitals don't lose, so that the patients aren't frustrated, and so that we can get the same care in a more efficient way and contract the beds and the services to the patients, that don't need to be there as long, and focus on the sickest patients that really do need the longer lengths of stay. So 2 points I just wanted to raise.
That's great, and I think also really speaks to what Gabe was saying is that hospitalists, everybody in the hospital, and the EDs need to work together because there are solutions that can solve the problem in the ED from upstream. So
I think the whole thing about insurance approvals and getting people to subacute rehab and whatnot, really, some group or subset here or the regulatory agencies really need to take a deep dive into this, because this is a huge barrier, which I don't think you can get anybody out except on a Monday, Tuesday, or Wednesday. That's sort of it.
Question in the back, Isha.
Hi.
Sorry.
Had one over here.
No, go ahead.
Joanna Hyatt-Kim with the American Hospital Association. My question is for Dr. Pines. The system of hospital penalties as a solution that you outlined really puts the onus on the hospital to solve the issue entirely. And so I would ask if there were ideas to, as the woman just mentioned, help with the insurance side of things, discharging patients and improving output, getting at the post-acute discharge problem that we're seeing, which will likely get worse with the new CMS staffing rule. Were there ideas that you had around that?
I think there are a lot of different ways you can address the issue. We mentioned prior authorization. You can impact the input of patients into the system. Where they go. How people are move around within the system, the size of that system, how fast people move out of the system. I mean, it's just basically, there's a lot of things you can do. I think having a direct financial incentive is important, and the reason for that is because it puts the priority high enough on the list that hospitals would implement these the fixes that are out there. I mean, it is a fixable problem. if you have the right incentive and the leadership and the wherewithal to do it. It's a hard thing to do, but like Peter said, if you do it right, it's actually better for the patient. You make better use of space. You don't actually need more space, and the whole system runs more efficiently. So I think and maybe I'm not sure if the thermonuclear option is the right incentive there, but there needs to be something, because what we're seeing today is benign neglect because there is no incentive. Because the incentive sort of tilts the other way. That what we see in American healthcare and everywhere, it's called form follows finance, right? If you build a system with certain incentives, you will get the exact results that you built the system to that the system incentives essentially will drive the structure of that system. So maybe it's not these hard incentives, but something needs to happen.
With all these obstacles, I just wanted to say, in an appreciation for all these obstacles, we still have the question of why can't anyone leave the hospital before 5 o'clock in the evening? Even if they don't need home health care, they don't need rehab, they can just go home. But we can't seem to get them out of our institution till 5 or 6 in the evening.
Okay, Aisha.
Just really quick before we wrap up the morning, I don't think I heard any mention of patients and patient advocacy groups and their role in terms of helping us come up with real solutions. We know that there are a lot of patient advocacy groups that are incredibly powerful and engaged, and if patients really were aware, I think, of some of the details in terms of this crowding and prolonged lengths of stay in the emergency department, to the tune of being charged really for inpatient services when they're not getting inpatient services. They're in the emergency department in some instances. So just from that lens, I think that there's an opportunity to be really transparent with patients and engaging patient advocacy groups to partner with us to come up with some real solutions, because I think if they knew some of the details, they would be really outraged. And that's what it's going to take, I think, to come up with some real solutions.
Thank you for that. I think that's an excellent point, and we are grateful for the patient advocacy groups that were involved with us in this planning and helped us to find some of the folks that you heard from this morning to tell their stories, and I certainly hope that there are more of them online today. I think it was actually surprising for at least one of these groups to understand the scope, breadth and depth of this problem. And I think some of the issues you're talking about in terms of cost, different from the effects that patients understand at first blush, would only deepen their interest in this issue, as you say. Are there other questions? Oh, yep, you're up in front. Oh,
yeah, Stephen Stack. So with the government side, I think we should all be very careful and go light touch there. It's sort of like turning a barge. A little nudge has a big impact down the road, and you can't, it's like pulling a string in a spider web. You cause the whole thing to vibrate, and you cause consequences you don't desire down the road. So, and I've never been a fan of the stick part of the programs, because the stick seldom makes the situation better. Just people optimize the variables, and the commercial payers and the for-profits are able to move much more nimbly than government regulation ever could hope to move. So, maybe if we look at this is fundamentally an intractable problem. It's fundamentally not solvable, but it is mitigable. It can be made better than it currently is. And in fact, I think a lot of people have made the case it has to be made better. So perhaps incentives, like a site of service differential on Saturday, Sunday surgeries at a facility, you may just find if you gave a 10% premium or something on payment rates for surgeries done on Saturday and Sunday, maybe young surgeons who are more hungry or aggressive might be willing to do stuff. And if you match that with the facility side, maybe we could incentivize. And if we get the outflow better, it should improve other aspects of the performance of the system. There's other considerations, I think, when we look at this, that we have to be careful really about the regulatory side. Some of those of us who are in government understand and are willing at times to be the kind of the fall person, if you will, or or the bad guy so that others can do what needs to be done. But that really only goes so far. And so that, again, has to be used with some kind of judiciousness as well.
Thank you for those words of caution.
Can I add on it?
Real quick.
So just to continue that thread about sort of the role of government, where we can start. I remember from my time in administration, this was one of the key issues that we heard from ACEP and AEM, and there were calls for us to take this seriously as an administration, right, to sort of put the focus on this issue. And so I want to just share, first of all, to the team at AHRQ, thank you for giving us a space and for doing the work of convening and bringing us together. It's an incredible and important first step. But secondly, I think that there's more that we can do, right? So for things to happen quickly in the administration from an executive standpoint, IPCs or interagency policy councils are often sort of the quickest way for folks to kind of convene across different agencies. And I think that's one of the directions that I'd love to see this now go, right, to sort of formalize this into an IPC with HHS and CMS, AHRQ, and the White House Domestic Policy Council to really begin to take a look at what can be done via executive action, what can be done via legislation, to really sort of put these things into gear and not just talk about it anymore.
Terrific. We have time for one last question, and there's somebody up front, unless somebody else is already, it's hard to see with the lights. Oh, we got two somebodies up front.
Hi,
okay.
Ted
Real
Melnick
quick,
from Yale.
we've got somebody else too. Quick. No, you can go.
Okay. Sorry, Ted Melnick from Yale, academic and practicing emergency physician. This might be a little naive question, but I feel like it's a bit of an elephant in the room that we haven't discussed. So going back to the first session, in terms of serving the communities that our emergency departments are supposed to care for, and the payment reform that we're starting to touch on, I'm just curious from the group if there's any thoughts for how we might have payment reform that would be meaningful to actually care for our communities as opposed to be more procedurally oriented and smooth in that direction.
Does any one person want to take that?
Sure. So, I do work on value-based care in emergency medicine, and one of the things that I think that we should consider rethinking is how emergency departments get paid. Currently, we're like the fire department. We basically need to put out all the fires in the communities, but we basically get paid per fire. And I think if we move to a model where we were actually paid like the fire department, where we got paid per fire and for fire prevention with basically a fixed global budget, and with the state of Maryland does have a mechanism to do this, and to put some guardrails and incentives around really developing a model where the emergency department takes a central role in population health, as well as the needs of the community, and doesn't just sort of think about patients when they cross the threshold from the waiting room to the back, and have us move out into the community. I really think that creating incentives like that could really bring a lot of the value we bring in the emergency department to the community, and I think a good example of where those incentives come into play are with the Kaiser system, so basically, which is a capitated model, integrated health system, and they don't just think about when patients come into their emergency departments or their clinics, but they've created systems to basically direct patients to the right level of care, make sure patients are doing the right thing, and then make sure that people are okay afterwards. So I think there are some feasible ways to move in that direction.
Great question. 30 seconds for the last one.
Sure. I represent a niche special interest group, which is children, which haven't really come up much today, but are still 20% of people, and have a really different boarding problem, which is that in most EDs, general EDs, which are 99% of hospitals or general hospitals, the boarding is really sick kids waiting for transfer. And so where do kids fit into this discussion, and how do people waiting for transfer as opposed to admission fit into this discussion?
That is a very important question, and we I think, as I said in the beginning, kids, behavioral health, rural, those are sort of all special things that need additional focus. This afternoon, we are going to have breakout groups, and they should come up in that breakout group to talk about these issues, and we'll hope you're staying and can join to drive that conversation. Agree with you. So please join me in thanking this amazing panel, and I welcome Sean Bruna back for some concluding remarks.
Thank you all. I know we're eager to get to lunch, but I wanted to have just a couple comments as we close out this morning session. I thought the session on emergency department boarding this morning was incredibly powerful. This clearly is not an emergency department issue. It's really a health system issue, and I think we heard some nice language on that as well today. We certainly learned about the impacts of boarding from patients and people on the ground, and this is a significant issue that impacts communities across the United States. As our guest spoke, I remembered my late father's experience with boarding in an emergency department and the anxiety I felt waiting for him to get through the department and into the intensive care wing. So many of us unfortunately share similar experiences. We have to do better, and we can. As we learned from the CEO and second panel, we have options. We don't have to believe the myth that this issue is too complex. I'm optimistic that collectively we can solve this issue. In the new year, AHRQ will publish proceedings from the entirety of today's summit, both from the morning sessions that just occurred and from convenings of experts that will take place throughout the afternoon. We'll publish and distribute the report broadly, and it is our hope that it will complement other efforts already underway and serve as a primer for continued and specific action. Before we close for the morning, I'd like to thank all of the federal partners, as well as individuals that work tirelessly behind the scenes to bring national awareness to this issue. There's far too many people to thank for this component, but I really want to acknowledge some of the federal partners that are in the room: SAMHSA, HRSA, ACL, IHS, AHRQ, CMS, ASPE, CDC, among certainly others that are engaged in these efforts. And I'd like to thank the Secretary's office for sponsoring this room and support on this critically important issue. I also want to thank the professionals that continue to make our healthcare safer, higher quality, more accessible, and more equitable. Many of you are in this room, but certainly many more are across the U.S. And most of all, I want to thank patients, families, caregivers that have experienced boarding firsthand. You've shared your stories with us. Your experiences matter, and you push us to work together to address this issue. We hear you, and collectively we can address boarding. We can do better, and we certainly will. While this concludes the morning session of the summit, our efforts to address emergency department boarding will certainly continue in the year to come. Thank you for your time.
Produced by the U.S. Department of Health and Human Services.